Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the conference president, Professor Ines Shaltut, for giving me the chance to be part of this elegant and highly scientific conference. Also, my deepest thanks to the chairpersons who are really, yani kulluku asatidti, and I really love, you're all my great mentor. And thank you, Dr. Hazem, for an elegant talk, actually. And we are now switching gears from technology into the genetics of diabetes, which is another complicated topic, actually. But I was asked by Professor Ines Shaltut to give specifically this talk. So this is the first thing that we usually have when we are having a diabetic child. So one of the things that we are usually asked is, did you feed your son too much sugar when he was a small kid to get diabetes? So the response sometimes from the parents, no, it's multifactorial, and it could be also a genetic factor. So it's not just one thing to cause diabetes. It's not only the genetics, but it could be environmental that cause this. So looking into the pathogenesis of type 1 diabetes, and I'm going to take you on a journey in different types of diabetes, so it's not specifically for type 1. So if you're having a gene, this gene is going to have, after the viral affection, leading to viral replication, affecting the direct beta cell lysis, as well as induction of the innate and immune response of the beta cell death, and finally leading to an autoimmune affection of the beta cell death. But actually, this is the whole beta cell mass. So even if you're having the genetic, you should have an environmental trigger. And I'm going to talk shortly about that. This will lead to the presence of autoimmune disorders leading to the anti-insulin, anti-islet cell, and the glutamic acid decarboxylase, as well as the zinc transporter. And you can see the progression drop of the beta cell injury leading to the decrease in the mass of beta cell. So just reaching the pre-diabetes, and after that into the clinical onset of diabetes. So you have been through a lot to get into this. So what is actually the pathophysiology that lead to the beta cell death? We have plenty of theories, but actually most of them are poorly understood. But the most important thing is the molecular mimicry, which is the viral infection, either the Coxsackie virus, the cytomegalovirus, and you can see here that the peptide sequence of those viruses, one of the major viruses that have been implicated for type 1, and now the COVID-19 is added to those viruses from different data coming, so you can see that they have also similar peptide sequence of the glutamic acid decarboxylase, and that's why they have caused the injury. Looking into the major histocompatibility region at chromosome 6, and you can see the major classes infected with type 1 diabetes, either the class 1, HLA, B, and C, as well as class 2, which is actually the DR, DQ, and DB. So looking into the genetics of type 1 diabetes, we have a lot to be implicated here. The most common one is the DQB1 and DRB1. So just simply switching one amino acid of aspartate at position 57, this will lead to production of beta cell injury by the autoantibodies, as well as you can see again, we have another protective HLA haplotype. So it's not actually those genes who are responsible, where you can see here different chromosomes, starting from chromosome 2, 5, 6, 9, 11, 14, 15, as well as 18. All of them are implicated at different loci that you can see that those patients are susceptible for type 1. But is it the same with the same ethnicity? you can see obviously, after even saying that the GQA1 and GQB1 haplotype are more susceptible and at high risk, but actually you can see here that even the ethnicity having a big impact, where the African Americans, if they're having 2 haplotypes, are having an increased risk by 45% of having type 1 diabetes, in response or contrast to the Asian, where they have only 11%. So we are all acquainted with the genome-wide association in type 1. So we have genes which is responsible for the insulin production, which is indicated in the yellow, the immunity in blue, and the beta cell apoptosis protection in the green, and still we have in the pink unknown genes. But it's not actually genes of the immune response which affects the beta cell or the T cell lymphocytes, the interferon, the cytotoxic lymphocytes, and the production of the macrophage and beta cell damage. But actually you can see that we have non-immune genes. And as I have mentioned, those are the identified genetic markers of type 1 diabetes. But as we can see, the complexity is added to the picture, because we don't only have the type 1 diabetes, but you can see that we have many patients, they don't have one autoimmune disorder, but you can see patients with inflammatory bowel disorder, multiple sclerosis, juvenile rheumatoid arthritis. So you can see the complex interaction between different genes leading to other systematic problems. Moving from type 1 into type 2, and they are the specialists of the adult diabetologists, but actually are seeing more and more cases of type 2 diabetes even in children. So it's just starting as normal and having the good beta cell function and a normal glucose tolerance into the impaired glucose tolerance ending into type 2. But actually, we have here risk factors for childhood type 2 diabetes, which includes the type 2 in the first or second degree relatives, high-risk ethnic group, obesity, the presence of polycystic ovary syndrome, acanthosis nigricans, hypertension, dyslipidemia, as well as non-alcoholic fatty liver disease. Add to this the obesogenic and diabetogenic environment. And you can see here in South Los Angeles, they have seen the highest concentration of fast food restaurants in the city. And actually, we can see the same thing when you're having the food court in our big malls if you're just walking around Cairo. So you can see this is the high caloric intake. So your genes loaded the gun, and your lifestyle will pull the trigger. What about the genetics of type 2 diabetes? Again, the genome-wide association studies that have shown us actually many candidate genes for type 2, but little certainty. And you can see here that some are affected by the beta cell function, others leading to insulin resistance, the fat cell obesity gene leading to obesity, some of the gene like the insulin growth factor binding protein 2 affecting the beta cell, as well as insulin resistance. And those are one of the genes responsible for the affection of the intracellular calcium-dependent cytoplasmic protease. And again, it involves in insulin secretion and resistance, and have been linked to the type 2 diabetes. And another one, which is the peroxisome proliferative activated receptor gamma. Again, it leads to decrease in insulin resistance and have been implicated in one of the target genes, oral hypoglycemics, which is the TZDs, and may be responsible for 25% of type 2% of cases. So just moving from type 1 to type 2, and just I wanted to show you, being a pediatrician, that the infant stomach capacity increases gradually. And this is the same as the information coming from the genetics of diabetes. So moving into another type of diabetes, which is the neonatal diabetes mellitus. And actually, in my university, in Ain Shams University, we have seen just last week 3 cases of neonatal diabetes. And those cases are increasing gradually because of the awareness of the genetics in those cases, moving into those genes who are having abnormal pancreatic development. And you can see the bunch of genes responsible for that. And another genes responsible for the abnormal beta cell function, as well as destruction of the beta cell. So previously, we used to do a direct Sanger sequence, looking directly into the gene according to the clinical picture. But now we are using the whole next generation sequencing, testing for all targeted genes simultaneously, so you can get the genetic before even the clinical diagnosis. So this child, his name is Ahmed, of non-consanguineous parents. He was diagnosed with neonatal diabetes at the age of 1 month. And actually, any diabetes before the age of 6 months, this is a straightforward monogenic diabetes. So you have to know the implicated gene in order to decide not only the type of therapy, but looking into other systematic affection. So the genetic testing was done for the child, leading to see that he's having KIR6.2 gene mutation, and you can see here that the ATP sensitive potassium channel on the beta cell is responsible for that. So if you're just simply looking how it works with the presence of the glucose leading to the potassium channel closure, depolarization, and then the calcium channel opens, leading to insulin secretion, and that's why to have a good glycemic control. So if you're having a child with a KIR6.2 mutation confirmed by the genetics, you can easily switch this child into taking sulfonylurea, where you can see that this will lead to actually the activation of the mechanism that we have said about how we do this gradually by decreasing the insulin dosage with a special protocol and increasing the sulfonylurea. So you can see by this that Ahmed was actually stopped insulin, having sulfonylurea on 0.46 milligram per kg per day, excellent glycemic control with also very optimal growth with no complication. Another gene implicated for the KIR6.2 is the Den syndrome. Those one of the children that, this is not the photo, but we have another similar case in our hospital now. And you can see here even this publication just 2 months ago. So Den syndrome with this mutation coming from a big group, they did not only respond to high-dose sulfonylurea, but for the first time also responding to steroid. And you can see here the continuous glucose monitoring starting at the age of 2 weeks of age and then increasing into 1.5 years of age. And you can see the flat line response to both sulfonylurea and even for the EEG when they have a status epilepticus, the marked improvement when you have increased the steroid. Let's take another note, a child with neonatal diabetes, wide base gait, and even we have looked at, he has a normal developmental height and weight, and you can see here that he has a liver of 6 centimeters below the right costal margin. So the child is of consanguineous marriage. He had 2 sisters, 1 brother and 1 sister, totally normal. But another child who has died because of respiratory distress, he was diagnosed with pneumonia. Most probably this pneumonia was diabetic ketoacidosis and was misinterpreted as pneumonia, but it was actually DKA. And you can see here one of the most common implicated gene, which is the eukaryotic translation initiation factor 2, alpha kinases 3, and this is responsible, this is a novel missense mutation that was found in this gene, having the Wolcott-Rallison syndrome, having neonatal diabetes, hepatic, skeletal, as well as renal affection. It is seen also as the most common implicated gene in neonatal diabetes in the Gulf area because of the high consanguinity. but it's actually not the same in Egypt as well as in Europe. So the most common implicated gene, as you can see in the publication, here in Egypt is the potassium channel, but in the Gulf country is the Wallacott-Rallison syndrome. We have other genetic syndromes that you have to look for. So it's not only diabetes, but look for the thyroid, look for the chronic diarrhea as the IPIC syndrome, look at the anemia as well as the mean corpuscular volume, because you have the thiamine responsive megaloblastic anemia as a Rogers syndrome, and you have to look for the diabetes insipidus, diabetes mellitus, and optic atrophy and deafness if you're having the Wolfram syndrome. So you can see different system affections. And let's go with the quiz time. This is what she has also neonatal diabetes at the age of 6 months. And I had a call from the father. He told me that the young girl of the cousin, Taghreed, she also developed neonatal diabetes at the age of 4 months. So now we're having these two consanguineous parents, and both families are first-degree cousins. Both girls having neonatal diabetes. And looking at the family pedigree, asking both parents if they're having diabetes, both mothers said that they had gestational diabetes, and both grandmothers and grandmothers were diagnosed with type 2 diabetes and were on oral hypoglycemic therapies. So when you're looking as a family as this, we did genetic analysis, and here what we got, that they have mutation in the glucokinase, another missense mutation, and whenever actually I send the genetic analysis, I usually have a report of a novel missense mutation. So we have a lot in our cases. Actually, both children were homozygous mutation for glucokinase, and both parents were heterozygous. And look what we have here, that both girls neonatal diabetes, both mothers, the heterozygous of glucokinase leading to the diagnosis of MODY2, and then you can see even the fathers are also heterozygous. So you can see the same mechanism, but I wanted to show you the importance of the glucokinase if you just need to have the glucose 6-phosphate and then activation of the same pathogenesis and mechanism in order to make the insulin release. So what is actually seen in the glucokinase? The higher setup. And so it's totally different than other types of monogenic diabetes actually. I'm just going to wrap up. So if you're having a mild, till they can get back the presentation. So if the difference between the normal and the glucokinase is that the glucokinase is having a higher setup point. So just it's similar to the normal, but with a higher setup, fasting blood glucose of less than 40 milligram per deciliter. And this is actually totally different than the hepatic nuclear factor and other types of diabetes, but it's still not working. So you can see even that both diagrams are okay. So please just to take a note about this. This is very important. If you're having a child presenting with neonatal diabetes, always test the parents. So if the parents are having affection of the blood glucose, even a higher setup point, those who are saying that they're having either prediabetes or those are having a little bit impaired glucose tolerance, and specifically for those having gestational diabetes, this means that most probably that the child is having glucokinase mutation. That's why some parents, if they are heterozygous, they even respond to a very similar thing, which is just into the lifestyle and the exercise, totally different. and I'm going rapidly with the other slides, because now we are having the type 1, the type 2 diabetes, which is different than the hepatic nuclear 1 alpha. And you can see the rise of the blood glucose if you're having the glucokinase rather than having the 1 alpha. This is very important because the family usually asks, if I'm going to have another child, is he going to have diabetes? So the risk is 25%. Very interesting point. A same gene can cause 2 different mutations, that we have seen it a lot actually. So if you're having activation mutation of the glucokinase gene, you're having hyperinsulinemic hypoglycemia. And if you're having inactivation of the glucokinase gene, so heterozygous will lead to mild fasting hyperglycemia as seen by the parents. Homozygous is leading to permanent neonatal diabetes. Same gene, 2 different spectrum, 2 different diseases, hypo into hyper, whether we are activation mutation or inactivation mutation of the glucokinase. So it's not just simple thing. You can see here that along the differential diagnosis, looking into type 1, type 2, and monogenic diabetes, look into the signs. If your child does not go with the type 2, he's not obese and he doesn't have any acanthosis nigricans, the MODY is very important. If you still having minimal need of insulin and you don't have autoantibodies. I'm not going through this because of the time, but you have a specific forms of the hepatic nuclear factor 1 when you have a low renal threshold, you have a low high sensitive CRP, as well as a very good thing, which is elevated HDL, which is not even seen in type 2 diabetes. For MODY 5, it's very specific to have renal cyst, and usually we do the ultrasound for those patients to detect different types, even if we are still waiting for the genetic types, and sometimes they have genetic abnormalities. So with this model of genetic personalized approach in order to see the type, you can see with this diagram how you're looking if your child is type 1, your child is type 2, or even your child is having monogenic diabetes. And please don't forget to look for the mother if she's having deafness or having diabetes, because or myopathy or stroke. This could be mitochondrial diabetes and Mellitus syndrome. So we have different types of permanent neonatal diabetes. Some of them are implicated both in neonatal as well as monogenic diabetes, but others are only involved in one type of diabetes rather than the polygenic part of both type 1 and type 2. So the important info here is we do not judge parents for just letting their daughters or sons having a lot of sweets to eat, because this is not definitely the factor for leading those patients of having diabetes mellitus. But you can see that genetic types of diabetes, although they are rare, but they are there. And honestly speaking, we have a lot of genetic cases in our countries, but we need to dig deep to know that. So molecular genetics goes to diabetes clinic. So whatever type of different cases we are having of different types of diabetes. So just to say that although the dissection of the genetics is still in its infancy, but it has great contribution to our understanding. And diabetes actually is more complex than the burden of diabetes and its complication. But the complexity of knowing the type of diabetes is not just simply classifying type 1 or type 2 diabetes, but we have a difficult diagnosis to reach in those children. I hope at the end to give you a flavor of the different types of the genetics and pathogenesis of diabetes and how each one can be adjusted according to the specific genes in those children. And please, at the end, never stop being inquisitive and look for this specific type of diabetes in your child. Thank you so much.
Thanks, Professor Nancy, for your elegant